start. Good morning, everyone. Please go ahead and scan the QR code when you join the meeting so that you get credit for being here this morning. And if you're having trouble with the QR code, please send me a message in the chat so I can record your attendance. Ken, do you know how I mute the ding? I don't know that part.
I don't know how to mute the ding.
Okay, that's fine.
but
I'm just delighted that everybody's able to join without me having to like admit them from the waiting room. So that was like my tech moment of the morning. Thank you.
There must, yeah, I don't.
I'm sure there's
because I'm not a host. Yeah.
It's gonna be fine. Everybody is used to the ding, and it's like part of our white noise at this point. It's the ding of the waiting room. It really is.
Love it.
All right,
Yeah.
and I'm gonna at 7:01. I'm gonna tell you I'm gonna give you the go ahead, okay? Because you know how I like to start on time.
Yes.
And I actually just really want to be respectful of everybody getting to their rotations this morning. So we'll give it another minute as everybody's joining, and then we'll get started. Thanks everybody for being here. As you join, please do scan the QR code so that you get credit for being here, okay? If you're having trouble with the QR code, please send me a chat. Okay. So good morning, everyone. We're going to go ahead and get started as people finish sort of filtering into our Zoom room this morning. Welcome to our first intern teaching conference of 2021. I am so excited to be here with you all. Last plug that I will make is scan the QR code before we get started this morning so that you get credit for being here. If you're having trouble, just send me a link, a message in the chat. All right, I'm going to let Ken do, Ken, did you want to say a quick hello or no? Am I getting that wrong?
Yeah. Yeah, just 12 seconds. Hi, everybody.
Hold on, Ken, hold on. Adam, can I, there we go. Cool. Go, Ken.
Yeah, no, I just want to say good morning to everybody. Welcome. I hope the first few days of your, of your first rotation have been going well. Welcome to Intern Teaching Conference. I'm going to turn things over to Gabby Berger. Gabby is one of our assistant program directors. She's an amazing teacher and educator, really one of the best in the university here. Gabby, thank you for organizing this conference series. And I know they're going to love it, and take it away.
Oh, thank you so much, Ken. Super kind. Hey, everybody. You got to make sure that you're muted. Okay, we got a lot of folks here this morning. So thank you for joining. And okay, thanks so much for being here. Last chance to scan the QR code, and then I'll show it again at the end if you have any trouble getting it. So there we go. All right. So good morning, everyone. We are here gathered today to start our first intern teaching conference. We are going to be together for the next 8 weeks in a row on Thursday mornings from 7 to 8 a.m. on Zoom. And I'll be sending reminder emails every week. Our Zoom link should stay the same. Ken and I are really excited to be here because this really represents our first opportunity to create and deliver content just for your level of learning. This lecture series is designed specifically to be highly applicable to the things that you are experiencing early on in your intern year. So core topics in internal medicine, in particular, things that you might get called about on cross cover, or those things that you feel like are just really practical management skills that you maybe didn't get in medical school when you were sitting in morning report, which is obviously so wonderful. So we're going to get started this morning with that very core skill of cross cover. So how to be a super intern, which you all are, tips and tricks for cross cover. I will be giving today's lecture. We have a series of really fantastic clinician educators set up for the rest of the summer, including Dr. Steinberg himself at the end of July, who will talk to you about an approach to shortness of breath. Before I get started, I will say we're going to use Zoom polls this morning. So I want this to be highly interactive. Ken is here for just a few minutes, but he's going to drop off to meet with the chiefs. And so I need somebody to help be my chat managers. So I was going to nominate my wonderful mentees. So Leah, I see you in the participant window. I'm going to ask you to help monitor the chat if it's okay with you, and Becca as well. I see you there. If you both could just monitor the chat and interrupt me, so literally unmute yourself, interrupt, and say, hey, Gabby, I think there are comments in the chat that we need to address. I'm usually pretty good at being able to monitor chat, but want to make sure that you all have an opportunity to ask questions. Okay. All right. I will present the QR code again at the end for attendance for anybody who wasn't able to scan it. And if you're having trouble with the QR code, send me a chat and I'll record your attendance. Okay, let's get started. All right, so this morning we are going to be talking about how to triage common cross-cover calls with a focus on practical skills for assessment and treatment. So we're really going to cover 4 very exciting topics this morning. And I realize they may not seem that exciting, but honestly, the vast majority of the calls you get will often fall into one of these 4 categories. So some form of altered mental status, nausea, vomiting, constipation, and insomnia. So we're going to focus on some core skills here. All right, so it is 9 p.m. Maybe you're on call, maybe you're cross cover, maybe you're the night intern, your pager goes off and it says something like this: doctor, your patient is altered. Okay, so here's our first case. You are called about a patient who's a 65-year-old gentleman with COPD, cirrhosis, and AFib, who's admitted for a new PE. He started on a heparin drip, nebs, and oxycodone with IV morphine for breakthrough pain. And the nurse is holding his evening meds because she's noted that the patient is somnolent. All right, so being the excellent intern that you are, your first step is to check your sign out. And you note that the patient is listed as a watcher. So that gets your attention right away. Here are some very basic labs. The creatinine's 2.1, sodium's 127. The other labs are normal. You note his vital signs, which I've written down for you here. So blood pressure of 100/60, heart rate in the hundreds, 92% on 4 liters. All right, and here's a basic exam when you go to see the patient. He has AFib, he's irregularly irregular, he doesn't have any edema. He does have some scattered wheezes, but no crackles. You know that he has COPD. And his neuro exam is that he's somnolent, he does arouse to voice, and he withdraws from pain symmetrically. You note there is no clonus on your exam. All right, so here is our first question for today. So what is the best next step? And I'm going to launch a poll in just a moment here. And so the question is it Narcan? Is it a stat CT of the head, stroke protocol? Are you going to get a stat Chem7 and ABG? Are you going to start 2% saline or start lactate? So go ahead and type in your answers. We're going to do a number of poll questions today. These are all anonymous. So please put your answer in. It's okay, you don't need to perseverate, but the idea is to get the temperature of where the group is. Okay, all right. All right, I'm going to go ahead and call it here. So I'm going to share the results. So it looks like the vast majority of the, well, I wouldn't say the vast majority, the majority of the group wants to get a stat chem 7 and an ABG. And there are some smattering of votes for a CT head, votes for Narcan, a couple of votes for 2% saline and lactulose. So this is great. This is exactly why we do this kind of question. So what would I recommend next? So I would go with the folks who suggested a stat chem 7 and an ABG in this case. And we'll talk a little bit about why. But before we do that, I think the most important thing is to think about really having a framework or an approach to altered mental status. This is a really challenging sort of broad syndrome. It is not a diagnosis. I want to be really clear that it's a syndrome, and it represents a vast majority, a really broad array of different presentations, from confusion to disorientation to agitation, for example. And so when you're thinking about altered mental status, your job is to really diagnose what's going on. So I'm curious, just go ahead and unmute or put in the chat, who has an approach to altered mental status that they like?
I've used the MIST mnemonic.
Nice, Adrian. One of my former students. Love it. MIST, anybody else? No? There's no right or wrong here. And so I want to be really clear about that. I don't think that, you know, the goal is to come up with a framework that works for you, and not that there's only one way to do this. And that's the rule of most things in internal medicine. I'll say every year I hear Vindicates is a pretty common one that students are aware of, particularly from UW. I like the MISTO approach, so close to what Adrian mentioned. And I like MISTO because I feel like it's short and it's something I can remember. Okay, I'm a generalist. There's a lot of things in my brain at one time. And so I can only hold so many things. And so MISTO is something I can remember. So what is the M? Metabolic and toxic causes of altered mental status. So this includes all of your electrolyte abnormalities, hypoglycemia, encephalopathy, like high ammonia, toxins like steroid induced. So that would be like a medication as a toxin, medication induced confusion or agitation, alcohol, drugs, etc. So metabolic and toxic. I stands for infectious. S stands for stroke or seizure. T stands for trauma. And O is for oxygen. And for me, that represents both hypoxia and hypercarbia. Okay. And so I like MISTO again, because I can remember MISTO. It's fairly focused, but it helps me think about and organize my workup and my approach to treating somebody who is altered. So I really use this mnemonic to help drive my evaluation for altered mental status, especially when I'm cross-covering patients that I don't know. Okay, I think that's often the biggest challenge, especially at intern year. All of a sudden, you're covering patients that you've never met before, and you only have information about on paper, right? And so it makes the cross cover and the triage more difficult. So when I'm thinking about metabolic causes of altered mental status, I'm going to order a Chem 7, a calcium, and then depending on the situation, you might consider a Utox. You might consider serum or urine osms. You want to go to the bedside and look for asterixis. And then always reviewing the medication list and the EMAR, so the electronic medical administration record, which is available in Epic, to see when patients last got their medications. All right, next, infectious. So I would review vital signs and do a basic infectious workup, which to me means UA, chest X-ray, blood cultures. Okay, UA with culture, chest X-ray, blood cultures, and some other basic labs that we just discussed. I want to highlight that rarely do you need to do an LP. Okay, when you think about altered mental status, everybody, when you think about infection, jumps to something like meningitis. I want to be really clear that if you're admitting somebody from the ER or from, you know, a new patient with altered mental status, meningitis is very reasonable to have on the differential if the syndrome, presenting syndrome, is appropriate. Meningitis is extremely unlikely to present in a patient that you are cross-covering in the hospital, right? Almost never is somebody going to like suddenly develop bacterial meningitis when they're on the floor. Okay, so I'm not saying never think about an LP in this kind of a situation when you're cross-covering and get called about an altered mental status, but it is rare that you would need to do that. Okay, if you're worried about a stroke or a seizure, the thing to do is a non-con head CT, remembering that that's going to show you blood, right? And then if you have a focal deficit, certainly you want to do a CTA, CT angiogram of the head and neck. And call neuro. That would be your workup if you were worried about a stroke, if there was a neuro deficit. Otherwise, a non-con head CT is fine. Trauma, again, is not something we deal with very much as internal medicine docs on cross cover. The common thing here is that we have patients who are anticoagulated and may fall out of bed, et cetera, you know, trying to get up in the middle of the night, and you may be worried about head trauma. And so in that case, a non-con head CT is really, again, all you need because what you're looking for is blood. Okay. And then finally, if you're worried about either hypoxia or hypercarbia, an ABG and a chest X-ray are your friends. So again, I like Misto because it not only helps me organize the possible etiologies of altered mental status, but it helps drive my workup and makes me feel like I have an organized approach to managing these patients. Okay, I noticed a comment in the chat just quickly. Number one, I'm recording this lecture and it will be posted for you all. And that's particularly for interns who are off or on post call for et cetera, et cetera. And we'll do that for all of our ITC talks, and the slides will be available to you all. Okay, they'll be posted on our ITC website, which I will share with you in an email. So you are welcome to do anything that you would like, screenshots, et cetera, with the slides, but you'll also have access to everything. Okay. All right. So you decide to go ahead and get a stat chem 7 and an ABG for this gentleman based on his presentation and the things that were highest on your differential. And you note that his sodium is 128, which is was 127 previously. Creatinine is 2.3 and glucose is 123. His ABG is 7.2, 78, 74 on 4 liters nasal cannula. Okay. And what does that help you with? You check his EMAR, so his electronic medical record, and you note that he received 4 milligrams of IV morphine at 6 p.m. It's now 9 p.m. if you recall. So what do you think's going on? Somebody can unmute themselves or put it in chat. What's the cause of this gentleman's altered mental status? Acidemia and respiratory acidosis. Awesome, totally agree. So this is a gentleman who had a number of medical problems that could result in altered mental status. He's hyponatremic. He has underlying cirrhosis, so maybe he became encephalopathic. He had, what else did I give you? I can't remember. But he also has acute on chronic renal failure, right? Acute on chronic kidney injury with a rising creatinine of 2.3. And I think the key thing to remember here is that morphine is renally cleared. And so it can build up in folks who have decreased renal clearance. He also has known COPD and is coming in with a bit of a COPD exacerbation. So he's at risk for becoming a bit hypercarbic. So excellent. You've identified that he's hypercarbic. You transfer him to the MICU, the medical ICU, for NIPPV, non-invasive positive pressure ventilation. This is the generic way of saying BiPAP. And you switch his morphine to hydromorphone. And we're going to have a whole talk on managing pain in inpatients in the hospital by Dr. Merrill in a couple of weeks. Okay, so before I go on to case 2, I see something in the chat. VBG as appropriate substitute for ABG when screening for hypercarbia, absolutely. ABG is sort of always the gold standard, but VBG very reasonable. So totally okay to do that. especially when you're looking for a pH and hypercarbia, not necessarily when you need a really good read on hypoxia, but good for hypercarbia. Thanks for that clarification, Joe. Okay, so case 2. We're still working through altered mental status. You've got an 87-year-old woman who's admitted for severe sepsis due to a UTI. She is treated with ceftriaxone, and now she's awaiting a SNF, skilled nursing facility. At 9:15 now, your pager goes off and the nurse is asking for a sleeping pill. You call back and find out that the patient seems off. All right, so being the super intern you try and get a little bit more information. Here are her vital signs. I'm going to tell you they look pretty normal. In general, she's picking at her blankets. She's trying to sit up. And when you do a neuro exam, the things you note are that she thinks she's at home. The year's 1925, and she's yelling at the little green men to get off the ceiling. So what's going on now? What's the cause of this patient's altered mental status?
Well, first thing I wonder is if there was anything like antimuscarinic or
Cool.
or something in the sleeping pill we gave her.
Nice. Awesome. And so that's a great thought. So always thinking about what did we give the patient? So the good news is that you haven't given anything yet. You decided to go see this patient first before you got anything. And you correctly identify that she seems delirious when you see her. Okay. And so what I really want to highlight with this slide is the unbelievable prevalence and incidence of delirium in hospitalized patients, okay? And particularly draw your attention to patients who are in the medical ICU with mechanical ventilation. Over 50%, almost up to 60 to 80% of patients, in this study develop some form of delirium. So I highlight this just because it is so common, and you will get called about it all the time. So the question is, how do you deal with it? So these pearls are not rocket science, but I think it's helpful to just remember that number one, you always want to manage pain. This can be tricky because you also want to minimize opioids in older folks, which can cause delirium. So this is tricky. Thinking about urinary retention and constipation, it's quite remarkable how urinary retention and constipation can make people feel really uncomfortable and a little bit crazy, especially when they're already disoriented in the hospital. So addressing some very basic functions for folks can really help. So avoiding opioids and sedating medications, particularly in folks with an underlying sort of poor brain substrate, is going to be really important, especially in older folks as well. And then really the things, a sort of like core bundle for delirium management is trying to prevent the complications. The brilliant thing is that at both UW and Harborview, we have a delirium power plan that you can use. And so if you pull up the delirium power plan, it will automatically order for you a bedside commode, safety mat, sleep hygiene measures that the nurse can implement. It helps empower your nursing colleagues to remove lines, tubes, and restraints, okay? And it really encourages frequent reorientation. So a lot of this is done by your nursing team, but requires a lot of great communication between you and them. Okay. All right. So what about when those things are not enough? So we do have 2 medication options that I'm going to submit to you for management of delirium in the hospital. Okay. And these are the two medication pearls I want you to file away. One is Haldol, haloperidol, and this can be given both PO and IV. Okay, so if you have a patient who is not able to take PO for whatever reason, then Haldol is an option because you can give it IV. Quetiapine or Seroquel is a great option in the hospital, but is only available PO, and so is limited in that way. All right, things to remember when you're prescribing medications for delirium. You always want to start low and go slow. So you can always add medication on, you can increase the dose. It's really hard to go back the other way. A reminder to check that QTC, make sure it's not over 500. That's sort of my arbitrary cutoff for thinking about safety with these medications. And then you will hear, and you probably have heard about the increased mortality in older folks using some of these medications, particularly with dementia. As a primary care doc, I think about that a lot. These are medications that do have mortality risk in folks over time in the chronic setting, long term. Short term, it should not be a problem. That should not stop you if you feel like you need medications to for the safety of the patient. Okay. All right, so back to our patient, our 87-year-old who's waiting for sniff, who's getting oxycodone every 6 hours. You note that she has low urine output, so you order an INO cath, or also known as a straight cath. She drains 1 liter of clear urine. She feels so much better from her urinary retention because of the opioid that she was getting. And she promptly goes to sleep, and you don't even need to order that sleeping pill. And of course, everyone thinks you're a super intern. All right, so we're gonna wrap up altered mental status with something I call a quick take. Okay, so we're gonna move rapidly through this case. And I'm gonna make sure that everybody's muted. Thank you. Okay, so we have a 78-year-old man with metastatic lung cancer who's admitted for pain. You are called as cross cover for a new onset seizure. So 5 minutes ago, the nurse witnessed a generalized tonic-clonic seizure that lasted 60 seconds while the nurse was administering medications, and the patient's now unresponsive. During the seizure, the patient's O2 sats dropped to the low 70s, but now he's back at the low 90s on 2 liters. So the question is, what is your best next step? And I'm gonna share a poll with you. Okay, so do you want to give IV lorazepam 2 mg IV now? Do you want to give a phenytoin load? Do you want to give levetiracetam, which is also known as Keppra? Do you want to observe and order a brain MRI with contrast? Or do you want to do a stat ABG? All right, remember this is totally anonymous, so go ahead and pick your best choice. It's just important to put your nickel down. That's how we learn. It's okay to be wrong. Okay. Excellent. All right. So I'm going to share the results here. And as you can see, there's quite a spread, which is great. That's exactly why we do questions like this. So I'm seeing a lot of votes for a stat ABG, maybe because of that low stat that we just, and the discussion we just had. I see a lot of votes for lorazepam, but some votes for the others options as well. Okay, so I am going to share with you that in this case, I actually think the next best step is to observe and order an MRI brain with contrast. And we're going to talk about why, okay? But the thing to remember here is this is a gentleman that comes in with known metastatic lung cancer with a new onset seizure, okay? That has stopped by the time that you see the patient. All right, now, so you order that brain MRI because the patient has stopped seizing. He's post-ictal, but he's protecting his airway. He's awaiting the MRI. The nurse pages that the patient is having another generalized tonic-clonic seizure. Okay, same patient. Now what? And we're gonna repeat that same question. So same answer choices. What are you gonna do now? Second seizure. Great. Fast and furious. I love it. Everybody's putting in their answers here. Great. Okay. So now we have a lot of people wanting to do lorazepam, a couple of votes for phenytoin and a couple of votes for levetiracetam. I totally agree. Now, I think the right answer is lorazepam. Let me tell you why. So for acute seizure management, which is something that you will get called about on cross-cover, the rules of thumb are: number one, for a first-time seizure that lasts less than 1 to 2 minutes and breaks spontaneously, meaning you're called about it by the nurse, but the patient is either stopped seizing by the time she sees, or he or the nurse sees the patient, or by the time you see the patient, et cetera. If it's a short seizure, you can just observe the patient. And in this case, because it was a new onset seizure, it's very reasonable to do some head imaging to understand why. And in this case, probably it's metastasis from his brain, from his lung cancer. Okay. But for a seizure that lasts more than 1 to 2 minutes, or a recurrent seizure, so now it's the second seizure, then you really want to treat with IV lorazepam. That's your go-to drug, and the dose is 2 mg IV. Okay. And then for ongoing seizures, This is really when we think about either a phenytoin load or giving levetiracetam, which is Keppra. For acute seizure management, typically for ongoing seizures, we reach for phenytoin. But for intermittent seizures, or if neuro, for example, is worried about recurrent seizures, they may just go for levetiracetam or Keppra. Okay. So really what I want to focus on is in that moment when you're called for acute seizure management, if the seizure is broken spontaneously, you don't need to give them Ativan or lorazepam if the seizure is done. If they have a recurrent seizure or are continuing to seize, that's when you want to give Ativan or lorazepam. Okay. All right, so our take-home points for the altered mental status, and this is the topic we spend the most time on in the morning. I really encourage you to use a framework. I like MISTO to organize the differential diagnosis and drive your workup for altered mental status. Choose a framework that works for you, whatever it is. Just use the same one over and over again so you get comfortable with it. Number 2 is to treat delirium with environmental modifications and use your medications as the last resort. But if you do need meds, haloperidol and quetiapine are what I would reach for in the hospital. Haloperidol is IV. And then finally, use lorazepam for acute seizure management, and then phenytoin or levetiracetam for recurrent seizures. And if the seizure has broken, you don't need to treat them with Ativan. Okay. Why would you get an MRI first on this patient? So this is a patient, just the scenario is a patient with known metastatic lung cancer with a new seizure. So presumably he has metastasis, and that's going to be best seen on an MRI. If you can't get an MRI, you could do a CT with contrast, but it's going to, Mets are best seen on an MRI. So it's just for this particular patient. But the point is thinking about whether or not to give meds in this situation or not. Great question, Lily. All right. Maximum dose of phenytoin for an ongoing seizure. Good question. It's actually a load. So it's a weight-based load that will be in, that your pharmacist will help you with. So you can either order it directly through Epic, and it's orderable as a weight-based load, or if you're having any questions, you just, the pharmacist will help you weight-base the dose. Someone seizes times 2, you load with an antiepileptic in addition to aborting the seizure if still active. Yeah, so if still active, so I would say you're giving your Ativan if that's not breaking the seizure, then you start the phenytoin load and you're transferring to the ICU, because if you can't break a seizure with lorazepam, then you're moving into like a status epilepticus situation, and those people are going to need more medication and to be closely monitored in the ICU, because everybody becomes hypoxic briefly during a seizure, but if they are continuing to seize, then that period of hypoxia is getting prolonged and they may need intubation.
Hey, Gabby, can I ask you a follow-up question on that?
Yep.
So would you load with like for seizure prophylaxis in the case of, you know, if that second seizure is aborted, but they're still on the floor, they're stable, would you load with like Keppra just for seizure prophylaxis, or are you only loading if they're actively seizing and it's not aborting?
No, so I would then use, the terms are slightly different there. So instead of loading, I would then think about prophylaxing. I'd probably start Keppra for prophylaxis. You're going to probably call neuro in that situation. And if there is a high concern for ongoing seizures, they might go with phenytoin, Fosphenytoin is if they get hypotensive, but it might go with phenytoin, or they might choose Keppra, but it would be probably levetiracetam or Keppra in that situation for prophylaxing future seizures. Awesome. And I'm happy to stay at the end of the talk this morning and answer more questions if people have questions. Okay, let's move on. Doctor, your patient is constipated. So exciting, so common. Okay, you're going to get a billion pages about this. All right, so here's your patient, 66-year-old man who is admitted for left lower extremity cellulitis with volume overload. It's hospital day 4. You're getting paged at 11 p.m. for mild abdominal discomfort, but no bowel movement since admission. And you are admitting another patient in the emergency room. So the question is, what do you do next? Here's your poll. Are you going to give Docusate, Bisacodyl PR, which is a suppository, senna, a tap water enema, are you going to get more information? Cool. Fast and furious. I like it. We're going to keep things rolling here this morning. Okay. I'm going to go ahead and end the poll. I'm going to share the results. You are so wonderful. This is why I love beginning of the year interns. You are so really thoughtful and fantastic about wanting to get more information. Okay, so is that always the right answer? And I'm going to argue that in fact, getting more information is not always what you have to do. Okay, and in this case, I would actually suggest that you could probably order this gentleman a suppository, bisacodyl, or a tap water enema. Why do I say that? All right, so the question I'm really asking is, what is the minimum amount of information you need by phone to evaluate constipation? And the reason I'm posing that question to you is because for anybody who's been on an admitting rotation yet or on cross cover may have felt something like this, right? So you're getting paged like crazy, right? And part of your job now as an intern is just trying to figure out how do you triage all of these pages that you're getting. Okay. And so the question is, where do you need to focus your energy, and what can you deal with or triage quickly? So I'm going to suggest that when you get paged about constipation, which happens all the time, you really want to ask yourself, is this a symptom of a more serious condition, or is this just constipation? Okay, so things to ask yourself: does the patient have a new fever or other vital sign changes? Do they have risk factors for obstruction? If not, it's usually okay to treat these folks empirically. And then the question you ask yourself is, do you want to start from above or below? Okay. So when you're thinking about constipation, the time frame is always what I come back to. Do you want that patient to have a bowel movement now? By morning is fine. They're a little uncomfortable, but you've got a little time. Or sometime this month, whatever, it's fine, not a big deal. So I'm going to suggest that most people, when they're complaining of constipation in the hospital, are not interested in having a bowel movement sometime this month. But when you use medications that are slow, it will take days for them to work, as opposed to meds that work moderately quickly within 24 hours and meds that work quickly. Okay. So slow medications are things people use at home, and I do not prescribe in the hospital. Okay, this is not going to be helpful for people who are acute or feeling uncomfortable from constipation. And remember that there have been a number of studies that show that Docusate also is no better than placebo. So I do not use this medication at all anymore. I never prescribe it unless somebody is on it at home and they are so fixated and wed to their Docusate that that's what they want, also known as Colace. Otherwise, I don't use it. I love things in the moderate category. So formulations of polyethylene glycol, Miralax, or Go Lightly. Okay, Go Lightly is what we use for colonoscopy prep, but Miralax works very well. You can dose it many times per day. Lactulose also is an osmotic agent that in very small doses can be extremely effective. Tastes horrible, so patients may not like you, but it's effective. And then remember that Senna, Senecot, and bisacodyl are both stimulants that work moderately quickly. For patients who want to have a bowel movement now, okay, suppository with bisacodyl is a great option. A tap water enema is a great option, or something. And so those are both from below. Something from above is magnesium citrate, which is a saline laxative and works super fast. So if you're going to give somebody mag citrate, warn them that they need to be near a toilet. Okay, this is what I reach for in the hospital, not the stuff on the slow side. All right, so I would argue that sometimes with constipation, you don't need more information, but sometimes you might, okay? So here's a 38-year-old gentleman with sickle cell disease who is admitted for a vaso-occlusive crisis. His past medical history includes a ventral hernia with intermittent SBO. It's a small bowel obstruction. He's using a PCA, so a patient-controlled analgesia to give himself opioids for his pain. And he's on scheduled Senna and bisacodyl, which are good medicines to use in the hospital. But on hospital day 6, he develops new abdominal discomfort with constipation, and that does not improve with a bisacodyl suppository or a tap water enema. So being the excellent intern you are, you think, gosh, this seems like a little bit more there are some risk factors here. He's had a history of SBO in the past. So you get a KUB, an abdominal x-ray, and you see this. Anybody want to throw something into the chat about what this might look like? What do you think is going on for this gentleman? Ileus, thanks Ruth, totally agree. Yeah, this looks like somebody has an ileus, right? Perfect. Okay, so for this gentleman now, oops, I'm sorry, I was sharing the results of that last poll this whole time, I'm so sorry. What is the best next step for this gentleman? Here's our poll. Are you going to give methyl naltrexone 12 milligrams sub-Q times 1, naloxone orally? Are you going to place an NG tube and give go lightly drip? Or are you going to give a gastrographin enema and repeat it if there's no bowel movement? All right. Okay. Oops. I'm sorry, hold on, I did something funny to my screen. Sorry, okay, let's end the polling and share the results. Okay, so we got quite a bit of different options here. What I would say is that I actually agree that the best next step is methyl naltrexone, okay? And that is because of what we're going to talk about next. So what we're really looking at is options for really bad constipation, okay? And I want to introduce you to 3 different medications that you can use for really bad constipation in certain situations. So methyl naltrexone is an opioid antagonist that does not cross the blood-brain barrier, so it does not precipitate withdrawal. And it is really, really useful for people who have severe opioid-induced ileus or constipation. Oftentimes people on extremely high dose opioids in the hospital, maybe on a PCA, oftentimes for like a sickle cell crisis or cancer related pain. Okay. And so this can be really effective for those situations. Polyethylene glycol or go lightly drip through an NG tube is particularly helpful for patients who have CF and may have something that we call DIOS or the distal intestinal obstructive syndrome. We see that at UW not infrequently because we're a CF referral center. And so this can be a really helpful trick for folks who have inspissated stool, particularly in the small bowel. Okay, and then finally, the gastrographin enema is particularly useful for people who have impaction. So there's impacted stool from below. It can cause some electrolyte shifts, so you just need to check your electrolytes, but it's usually pretty safe. Okay, all right, so take home points for constipation. The key is that you do not actually need to do a bedside evaluation for every patient with constipation, but instead really choose the therapy based on how quickly you want results. Okay. All right, constipation, super exciting topic. I'm sorry, I keep forgetting to stop sharing those results. Okay, all right. DIOS is distal intestinal obstructive syndrome. And that is something that is that we see in particular with our CF patients with CF at UW in particular. Okay. Okay. So doctor, your patient's nauseated. So now it's your 27th page of the night. The patient is vomiting again. And here's your patient, a 51-year-old man with pancreatitis who was admitted 3 days ago to the medical ICU, treated with IV fluids and bowel rest, transferred to the floor today, still NPO. The vital signs are stable, but he is really nauseated. So the question is, what do you do next for this person? Okay. Are you going to go evaluate the patient? Are you going to give ondansetron 8 milligrams orally and finish your ED admission? Are you going to order ondansetron 8 milligrams IV, Q8 hours PRN, lorazepam IV, or find a bathroom and hide? You are just over it. Wow, I'm really excited about the finding the bathroom option. Many people choosing that. All right. Let's go ahead and end the polling here. I'll share the results. And again, people choosing lots of different things. Fewer people choosing evaluate the patient this time, maybe after our last discussion. And I really appreciate that. And I think that I'm going to go with the majority of folks here who want to do ondansetron 8 milligrams IV. And let's talk about why. So this would be my choice, 8 milligrams IV, Q8 hours PRN. And so I want to introduce to you the concept of the emesis ladder, okay? So this is my approach to treating nausea and vomiting in the hospital. So the first thing I always reach for is ondansetron or Zofran, 8 milligrams IV, Q8 hours. If that's not working, I move to metoclopramide, 5 to 10 milligrams IV, Q6, then prochlorperazine, also known as compazine, and then finally promethazine or Phenergan, okay? With promethazine, really trying to avoid IV if possible and start at the lowest possible dose. And that's because of its antihistaminergic effects. It can cause sedation and cause people to feel a high, okay? And the reason I go in this order is because of the increasing risk of side effects higher up you go on the ladder, okay? So when we think about medication side effects for the meds we use for nausea, remember that ondansetron is really very, very safe. It is an anti-serotonergic drug and may have some QTC prolongation, but generally very well tolerated. Metoclopramide is also known as Reglan, and prochlorperazine, also known as compazine, are both anti-dopaminergic. So they can have a risk of dystonic reactions, but this is actually quite rare. And the only time I've seen this is in one of my long-term primary care patients who has MS and had some other concerns and made her susceptible to dystonia. And she was taking it for a long period of time. And then finally with diphenhydramine, which is Benadryl, which you notice I did not put on my emesis ladder, and promethazine, which is Phenergan, both have antihistaminergic effects, particularly when you're giving them IV, they cause sedation and they cause a high. This is really common. So if a patient is asking for IV Benadryl or IV Phenergan, that is a red flag, okay? And it's not a never give, but it's a pause and think and talk to your senior or your attending before you give. Okay. I order ondansetron without an EKG all the time to answer the question in the chat. The issue is just glancing through the med list and making sure that they're not on a ton of other QTC prolonging medications. Okay. But generally speaking, it's very, very safe. Okay. So I actually feel like I wanted to skip this case. So I'm going to just get to the heart of what I wanted to tell you about with this case, which is when do you actually need to evaluate nausea in person? So coming back to this idea of like, does the patient need evaluation or not? And so for the patient with pancreatitis, this is a gentleman who came out of the ICU. He has known reasons for nausea, and probably just the person who was transferring him forgot to restart the ondansetron or forgot to prescribe that. So that doesn't necessarily need evaluation, but when do you need evaluation? So 3 scenarios that I want you to keep in mind. 1, does the nausea and vomiting make you worried about an atypical presentation of acute coronary syndrome? Okay, so does the patient have CAD risk factors? Are there vital sign abnormalities? Is there something new or different or concerning about the symptoms that would make you think, gosh, could this be an atypical presentation of ACS? Those are patients you definitely want to evaluate. Could the nausea vomiting represent increased intracranial pressure? So is the nausea and vomiting associated with new mental status changes, new headache or blurry vision? And then finally, is the nausea and vomiting associated with concerning GI symptoms? So is there coffee ground emesis, hematemesis, or new onset abdominal pain with that nausea and vomiting? Those would be patients that you might want to go see. Okay, so I would argue that you don't need to see all patients with nausea that you get called about on cross cover. And it's okay to write for meds without seeing a patient, but keep these 3 things in mind. And those are patients that you might want to see. You'll notice also on the emesis ladder, so I forgot to mention this, that all the meds I recommended were IV. That's because patients in the hospital, when they get nauseous, usually are pretty uncomfortable, and almost everybody has an IV, and PO just takes a long time to work. So like give them IV, and I don't worry about like transitioning people from IV to PO. As long as their nausea is well controlled on the IV, it's fine. Okay, so usually what happens is if we give PO, you're just going to get repaged about the fact that the patient's still nauseous and it's not working. And so I would just go to IV up front. Okay, so we are going to go skip through the next slide to this one, which is, of course, everybody thinks that you're a super intern, and this is my quiz for the day, my favorite quiz. Does anybody know who this superhero is? Okay, no takers on the superhero. Okay, so for anybody who is a parent of young kids, or who has young kids in your life, either as an aunt, uncle, or some other form of young kids in your life, this is Mia Macaroni. This is a main character from my kids' current favorite books about Mia the superhero. So if you need a great gift for 4 to 6 year olds, look for Mia Macaroni. All right. So take home points for nausea. You don't need to do a bedside evaluation for every patient with nausea. However, you do want to consider the possibility of more serious illness, like an MI, like CNS disease, or a GI bleed. Okay. And always try to avoid IV Benadryl, which is diphenhydramine, and Phenergan, which is promethazine. And if you do feel like you have to give IV, make sure you're discussing that with your senior or your attending. Okay. All right, so last topic today, doctor, your patient can't sleep. Also a super common problem in the hospital. Okay, so this is our last case for the day. So it's 2 a.m. and you're getting your 67th page of the night after getting your first page at 9 p.m. It's a 49-year-old man with left lower extremity cellulitis. He has a history of anxiety and depression, and he is requesting his home zolpidem, also known as Ambien, 10 milligrams to sleep. So here's your last question, our last poll. So what are you going to do for this gentleman? Are you going to go ahead and are you going to order trazodone, 25 milligrams, diphenhydramine, temazepam, zolpidem, or evaluate the patient? All right. Lots of good votes here. I'm going to go ahead and end the polling and share the results. Also a bit of a smattering. Some folks thinking about trazodone, some folks thinking about zolpidem, folks thinking about evaluating the patient. So I want to be really clear, evaluating the patient is never wrong. It is always great to evaluate the patient. Part of this morning is just trying to give you some of those tips and tricks to think about how to triage and to think when is it that you absolutely need to see the patient, and when can you think about prescribing without seeing the patient. Okay, so in this case, I think there are 2 reasonable answers here, either the trazodone or the zolpidem. And why the zolpidem here? Specifically because it's the patient's home medication. Okay, so that's what I really want to highlight, is that that I do not use, I think a lot of us are really familiar with the data about the risks of zolpidem or Ambien. And so it's not something I ever start in the hospital new, but if a patient takes it at home and they're stable, it's probably safe to use. Okay. So let's talk about a quick approach to insomnia in the hospital. So the first thing are those really simple things that you can help the nurse do to make the patient more comfortable. So environmental factors like lights off at night. It sounds crazy, but truly. Things that you can do are making sure that the patient is not in pain, that they're comfortable. Things that you can do as the intern is make sure the patient's not getting vital signs scheduled overnight. The default on many of our floors is Q8-hour vital signs. If the patient is admitted in the middle of the night and gets to the floor at 2 a.m., that means that the Q8-hour vital signs start at 2 a.m. And that sucks for almost all patients. So think about timing, retiming your vital signs for 10 p.m. and then again at 6 a.m. so that the patient has an 8-hour break in there. Nurses do a walkthrough every hour to look at patients and make sure they are safe and stable. So not doing vital signs overnight is totally fine as long as if you don't need them. Okay, and then think about rescheduling meds. Nothing is more horrible than giving somebody a dose of Lasix at 10 p.m., right? So like if you're signing out, eyes and O's and you want CrossCover to check on eyes and O's, have CrossCover do that at 5 p.m., not 11, okay? Your patients will appreciate you. When you're thinking about insomnia, you want to think, is there a concern for delirium, right? And that gets back to that second case that we did with that older woman who had been in the hospital for a long time and was delirious, and that's why she couldn't sleep. So get some more information from the nurse. If that's the case, if you're worried about delirium, absolutely go evaluate the patient and treat that, okay? And is this a chronic problem? Is the patient on home, on medications at home for sleep? If so, it's almost always okay to order those home medications, unless, again, you're worried about delirium or oversedation, okay? Again, I do not start zolpidem in the hospital, but if somebody's on it at home and they're not delirious, it's usually okay to give. So what about treatment in the hospital? Melatonin, super duper safe. It actually can be really helpful for a lot of folks. It doesn't work for everybody, but can be really helpful. And then trazodone, 25 to 50 milligrams at night, oftentimes extremely helpful. It's an antidepressant, old antidepressant at very high doses, but at low doses, it's really good for sleep. And it's good for short-term use, right? This is not something that we're thinking about using long-term in the outpatient setting for sleep, although we do it a lot, but the best data really is for the short-term use. And just a reminder that you really want to avoid benzos and diphenhydramine, which is Benadryl, in the hospital, especially in the elderly, because that produces a lot of paradoxical reactions and a lot of delirium. Okay, so take-home points for insomnia. Trazodone is very useful in the hospital, and that's your friend. Avoid zolpidem unless the patient takes it at home, and in those situations, it's usually safe to use as long as they're not delirious. And reschedule your meds and vital signs during the day to let people sleep at night. It will actually really help. All right, so in conclusion this morning, thank you so much for joining us. You are all super interns. I want you to remember to try and use a framework when you approach altered mental status. I like Misto. Choose one that works for you and stick with it. Constipation can often be triaged over the phone. Think about those situations where you may want to see the patient in person if you have concern about new abdominal pathology. But if it's just constipation, you can try treating it over the phone. Consider risk factors for myocardial infarction or a GI bleed when you're assessing nausea. Nausea can also often be treated over the phone when you're busy on CrossCover. But remember that there are times when you would want to see a patient in person to make sure you're not missing something more insidious. And then melatonin or trazodone for sleep. Those are your friends in the hospital. Okay. So that is all I have for you this morning. I am seeing a couple of things in the chat that I will answer. As I do that, I'm also going to ask you, if you came late and did not get the QR code, please scan that now. That's your attendance. I'm going to stop sharing my screen, and I'm going to put, no, I'm sorry, I keep sharing those, forgetting to stop sharing the poll results. I'm going to put the evaluation link in the chat. So please, please, please do an evaluation. I really value your feedback so I can make this talk better for future interns. And we'll do evaluations for all of our ITC talks. We do this every year. And again, we want to make this really valuable, useful information for you and for your colleagues moving forward. And then let's see, let me get back to the chat here. So almost all my rotations are at the VA, and order sense won't be applicable. Do you have any tips? So what I'm going to do, so you will all have access to all of these slides. So when you're at the VA, talk to your seniors. And the most, I think, effective way to handle a lot of these things when there are quote unquote order sets, so like for delirium, is to say, hey, what are the delirium? How do we enact a delirium bundle here at the VA? You know, or like, I know there's an order set at UW and Harborview. How do we do that at the VA? And your seniors and your nocturnists at the VA, who are amazing hospitalists, will be there and have all the answers for you at the ready. Okay. So I will, it looks like someone's interested in seeing the emesis ladder again. I will do that. The slides, yes, the slides will be posted for all of our ITC talks. After the talk is given, they'll be posted. I'm gonna email you. The reason I didn't email you the link for the ITC website earlier was because of the whole new website redesign. So, but it's ready to go. So I will email you the website later today, and you'll be able to access the slides from there. Okay. You'll also be able to access a recording should you want that, which I would not want that, but I would not want to hear me talking when you can just look at the slides. But if that is helpful to you, you'll also be able to access the recording on our YouTube website. And let's see, I will share. And for anybody who is done, let's see, I'm going to try sharing this again. Let's see here. For anybody who wanted to see are you all seeing what are you seeing? Are you seeing my email? Or are you seeing, no, you're not seeing my email. Are you seeing the slides? Okay, so here's the emesis ladder for anybody who wanted to see that part again. Okay, and I'll keep trying to look at the chat and answer questions that people have. But thank you so much for joining us, and have a wonderful day at your clinic. I will put the attendance slide back up in just a second. And then there was Lesitur Affertan. Is the person who asked about the seizure meds still on?
Yeah.
Okay, great. So the key there is really lorazepam is used to break an acute seizure when you're seeing a patient seize. Okay, and so like if you're called to a rapid response and the patient is seizing, you reach for lorazepam. Okay, if lorazepam is not breaking the seizure, the next step is a phenytoin load. Okay, if the seizure is broken and you're worried about recurrent seizures, most people will start levetiracetam. Does that make sense?
So you said start with lorazepam, and if that doesn't work, then you go to phenytoin?
Yep, exactly.
Okay, thank you.
Yep, you're welcome. Okay, and let me put up the attendance slide again. Cool. All right. Any other questions that I can help with? If not, feel free to log off, and we will see you next week.